Good afternoon and good evening, and thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, as well as the Africa health security and sovereignty agenda that Africa CDC is advancing. Today, we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. I will now hand over the floor to Prof to start the session. Over to you, Prof.
Thank you so much, Margaret. Once again, good morning, good afternoon, good evening to all of you, depending on wherever you are. I'm pleased to take the press briefing today, which is a very busy week. We are happy to be in Addis, where we'll have the 39th AU General Assembly, and then you will see in the presentation that we take advantage of the convening power of Africa CDC to ensure that once our head of state are around, we also take advantage to bring the health in the right political space. So we'll go through that, but also, of course, and then we will go to the presentation of the public health event that we are currently facing and responding in the continent. Over to you, Margaret. Okay, as you see in this picture, the AU General Assembly started with the Council Summit that happened. We'll come back to that. But prior to that, we have on Sunday, actually, in Ghana, the engagement of our DG with the President of Ghana, the President John Dramani Mahama. And the importance of this meeting is to ensure that there is a proper alignment between the Africa health, security, and sovereignty and the Accra reset. The Accra reset is this new way of, a new model actually of looking at the financing with the mutual respect, the global south being the one leading the proposal. So this is very well aligned with the AHSS, and then I will come back to that because tomorrow, one of the side events, will have the opportunity to have the President John Dramani Mahama be present to push this agenda of health financing in the continent. So as mentioned, the AU Summit, the General Assembly, the 39, has actually started by the opening of the 48th ordinary session of the African Union Executive Council with the Minister of Foreign Affairs. And it was the opportunity for our DJ to join and also to ensure that this agenda of health is part of the conversation. And looking at the theme this year, sustainable water availability and safe sanitation, you easily understand how critical the presence of Africa CDC is looking at an issue such as cholera. Appreciating that cholera is a disease that is dealt with the lack of access to safe water, which also have an impact on many other issues, including primary healthcare, which cannot function without safe water. And this was part of the discussion, which will continue as we have the side event during this week. So talking about the side event that Africa CDC and others will be hosting. So tomorrow on the 13th, we have the high-level dialogue on health financing. As mentioned, we'll have some of our head of state, including the President of Ghana, who launched the Accra Reset and push to ensure that it's also part of the AHSS. But we have other head of state that will be present together with the Minister of Health and Finance. That will happen in the morning, but also in the afternoon. And because we appreciate as Africa CDC and within the African Union that the health workforce is quite critical. We'll come back to that with the report that I will present some few slides, and this will be part of the high-level dialogue that will happen tomorrow in the evening. On Saturday, we'll have the presidential breakfast on local manufacturing in the continent. And in the afternoon of the same day, we'll have the high-level event reform on global health architecture. Now, specifically looking at those events, you can easily appreciate that they are also the key pillar of the Africa health security, and sovereignty. The health workforce, the digital transformation, which are quite critical, but also the community health workers, and of course, the local manufacturing. So this will be the opportunity to ensure that the technical discussion that we've been having for a while come to the highest political level, so that our head of state can really continue the engagement that the different champions have been carrying so far. And this is how Africa CDC, bringing those agenda at that level, ensure that we can actually see a transformation on the way we improve the health of our community, appreciating that this improvement cannot be done with the health sector alone. That's why we have the Minister of Finance, we have the Minister of Water and Sanitation as Kolera is concerned. This convening will allow us to ensure that we have a proper support and respond to the challenge that we are facing currently in the continent. Now, we also want to share, we are still on the alignment between the Accra reset, but also the Africa's health security and sovereignty agenda. We really engage you to go and read that opinion that was sponsored by Africa CDC on the title, Africa Can Pay for Its Own Health If We Choose Efficiency Over Dependency. And this has been cited by the President Dramani Mahama, but also the Chair Mahmoud Ali Yusuf and our Director General, Dr. Jan Kaseya. And the aim of this opinion is really to move from the old narrative that we depend on the aid and that we don't have the resources, but radically moving and appreciating that based on our data, what we've seen, that 40% of health spending is lost to inefficiency. We've seen, for example, that in DRC, a study has shown that the country is losing 800 million every year because of the ghost workers. So improvement in that will allow the country to have some money that can be reinvested in a more efficient way. So now looking at the efficiency is African new fiscal space. Now the idea is to reclaim $14 per capita annually, which could replace up to 50% of current donor financing within the 5 years. So it's about not asking much, but having more efficiency so that we can save some of the money that we waste because of some of our poor practices. But now also the fragmented system which undermines the sovereignty. We've learned now the one plan, one budget, one delivery mechanism, one M&E framework must become the norm, so that each country, each minister of health should know exactly for its country how much money is needed for his department, not how much money is coming from one partner, not how much money is going to one program. Really to have that comprehensive approach within one plan, and that will be a better and most efficient way of using the resources that are available. So you can see the alignment between the AHSS and the Accra reset, where Africa is really shifting from dependency to stewardship, financing health as a key pillar of the sovereignty, resilience, and also the security of the continent. Now, talking about the human capital, this is an important survey that was led by Africa CDC and UNICEF, the Africa Community Health Program. So this was a continent-wide community health survey to assess the status, but also the progress, the gaps, and the opportunity in community health system across the continent. We all agree that everything starts and ends at the level of the community. So it was critical to have that comprehensive snapshot of the national performance, as you will see in different countries, but also contribute to the foundational, which is foundational for Africa CDC Community Health Data Platform, but at the global level also to the CHDP dashboard. So it's a dynamic dashboard and a scorecard that will be regularly updated so that we know at which where the country has started and all the effort that need to be done to reach the threshold and the standard that you will be seeing just right now. So you remember our target of having 3 million community healthcare workers. As we do speak now, we've already reached 1.042 million. So around a bit more than 50%. And you can see the good gender where you have 51% of female and 49% of male. Now, when we look at the ratio, we are at the ratio of 7 for 10,000, knowing that our goal is actually to ensure that we have 25 for 10,000. You will see some of the countries that have already managed to achieve that. The average remuneration that are being seen per month is $50, and you can see there is a range between $10 to $432. So it's important to see how we can have the good practice where the countries that are managing are taking the resources to ensure that others can also learn from that. Now, looking at the comparison within the different country member states, we can see that so far the success is possible across different scale. We have 6 member states, 12.5%, which have already achieved the gold standard of 25 community healthcare workers per 10,000 population. So it is doable. However, we have 42 that fall short of this benchmark for different reasons. We have 21 member states in the quadrant 2 with a larger population, and then we have in the quadrant 4 those with both lower community health worker density, but also smaller population. So those ones actually represent the quick win with targeted investment. Now, when we look, we still compare at the continental level, we can see that 61% of our member states currently allocate national budget for community health program, which is already good and need to appreciate it. We have 51% of our member states, 26, which pay the community healthcare worker through the national wage bill, because that is the most critical way of ensuring the sustainability of the support of the community healthcare workers, but also we always go back to that, to the sovereignty of our countries. As mentioned, we have only 6 member states that finance over 80% of the community healthcare worker through the domestic funding, and we have 18 that depends on development partner for 90% of their community health program. So it's good that it's already existing. It is good that for now they have the partner supporting them, but we should really push and support so that they move toward a more sustainable way of having those community healthcare workers. And those community health workers are the ones that are so critical on generating some of the data that you are seeing. They are the one in the community ensuring that they involve in surveillance for outbreak response, but also for many other diseases. That's really the foundation of the primary health care. So now when we look at the top 5 diseases that we are seeing currently in the continent, we have cholera, which is definitely on top when you look at the number of deaths, 226, followed by measles, mpox, diphtheria, and dengue. And as you see, we have a lowest number of total events as compared to last year at the same time. This is really one of our key objectives of 2026, to have a lower number, or at least similar number of public health events as we did have in 2019, knowing that between the two periods, the countries have significantly improved on the surveillance capacity. So this will be a great indicator of the capacity that has been built in different countries, to the NPHI, to the PHUC, to quite a number of investment, but also to the fact that now, through our community health worker, we have the right information going in the community so that they can not only respond, they can have a better preparedness, and therefore the ability to limit some of those outbreaks before they occur. Going to mpox, yes, we remember mpox has been lifted as a fact, but still we have some countries, we have DRC, Guinea, Madagascar, Liberia, Kenya, and Ghana that currently accounted for 80% of the confirmed mpox case. Just before this briefing, we were engaging once again the team in Madagascar to see how they can accelerate the response, as I will show in the coming slide. So we have 32 out of the 55 member states that have been affected, and we keep on seeing that decrease, the peak for almost 90% from the week 17, 20, 25 to what we are currently seeing now. Talking about Madagascar, where we had very dynamic team who are in the ground, led by the NPHI there and the Ministry of Health, and they were sharing with us all the effort that they've been put in place on the side of the laboratory, on the side of the surveillance, but the need that remain on the ability to decentralize the diagnostic, because one of the critical challenge in those islands is the sample that need to move from one district to a centralized places. So the support that will be brought to them is on how we can decentralize the laboratory, as well as the support in surveillance, because it's critical to be able, as we've seen in many other countries, Sierra Leone, in Burundi, and so on, to really have the good surveillance, target the right population. As you can see, the test positivity rate has decreased from 77 to 43%, showing that there has been some great improvement on the active surveillance being done in the community. So that surveillance has to be integrated, as we discussed, so that the right population need to be targeted for when the 30,000 dose of vaccine will arrive. We are talking about the people living with HIV and the most vulnerable population, but also those who are in the most vulnerable position to actually spread the disease within the country. So far, we have 20 districts that has been affected out of 114. We have 229 confirmed cases, and out of 509 suspects. We can see that the number of contacts per case is 1 out of 4, which is quite far from the 1 out of 20 that we expect. But this is also part of the conversation that we have in the country to see how we can strengthen that capacity of active surveillance, despite the improvement that we are already seeing. In the nearby country, Comoros, we can see that they still have 13 cases that have been confirmed, 0 deaths, therefore a case fatality ratio of 0%. 2 out of the 3 islands has been affected. And as we've been saying, this is one country that has been very optimal in terms of preparedness, as they were seeing the case raising in Madagascar. So far, they're also pushing on the decentralization of the diagnostic, but also the case management with the 3 isolation centers that are moving in each of the different islands. So we are also supporting them on the preparedness to have a plan for the vaccination, so that they can also have some vaccine allocated, based on the epidemiology, of course. But one significant thing that you are seeing now, that you are also becoming kind of epidemiologists, the test positivity rate, around 17%, highlighting the strong active surveillance that is happening. We usually think around 30%. This is below, which means that there's still some adjustment to ensure that the right person are the ones that are being tested, so that we are also efficient on the way we are using the diagnostic test. In Liberia, once again, we can see that the surveillance is keep on being strengthened, as we can see once again with the same indicator, the test positivity rate around 25%. So far, they've reached the 1,603 confirmed cases out of the 3,000 suspected that they've been having. We still have the same place. Montserrado County and Nimba, they still account for the large majority of the case, almost 70%. One of the challenges that they still feel is that almost 6% out of 10 confirmed cases are isolated at home, which is a challenge, because we know that the most efficient way to stop the transmission is to admit all the positive cases at hospital. But this is when you have the capacity to decentralize the care. When you don't have, you push toward the home-based care, with the challenge that we are facing to strengthen the surveillance at home. Now, going to the issue of vaccination, I mentioned that Madagascar has been allocated 30,000 doses, so we are supporting them right now on ensuring that those doses will be used in the most efficient way, targeting the right population. There are also support to Comoros, Cameroon to support the next allocation. This is working toward having a proper plan and a proper demand. So far, 5 million of those has been delivered to 16 countries, both MVABN and LC16. But what is also critical at this stage is to appreciate that the large majority of countries have used more than 50%, but the minority that you see is being challenged. Why? Because of the issue of the operational funding. We know that some countries like Uganda have managed to collect to gather some domestic funding, but other countries have much more challenge to achieve that, especially a country like Angola, where they have no current case in the country. So it's more difficult, but definitely there is a support that they are receiving for the IMST to see how the dose that they have can be used, moving from the reactive to the preventive vaccination. Talking about it, we know that the LC16 has been used and is being used in DRC. Up to over 800,000 people have been vaccinated with the LC16, which is a bilateral donation between Japan and DRC. Now, it's important to increase the pool of vaccine. We have the MVABN, we have the LC16, important to see how this can go beyond DRC, but also looking at other vaccine, the mRNA vaccine. Because as we've lifted the mpox as effects, the next step is the control through the transition into the routine. And this also push us to move toward a herd immunity. And for that herd immunity to happen, we'll need to have those available to vaccinate in those endemic provinces, endemic countries, so that we can have that control and prevention. And as you guess, more vaccine being needed also push our agenda of local manufacturing, because we know that we have a large number of population to vaccinate to ensure that we control this disease moving toward its control at the country level. Now, we've added this slide that is showing the current flooding in Zambia that has started on the 3rd of February, which is currently up, and this slide is in Zambia. But we've seen also yesterday or 2 days ago, there were a cyclone on the side of Madagascar. We also see that in Mozambique, as you will see later, those flooding has been happening. Just to also re-emphasize that the climate change has those critical implications, because those heavy rainfall leading to flooding will then cause the waterborne disease, which include cholera, which I'll be showing later, but also the vector-borne disease, malaria, dengue, and so on. And also, the last but not the least, the zoonotic and environmental exposure risk, including leptospirosis and exposure to toxic substance or chemical. Now, looking at Zambia, it's important to have a regional approach. Now that we see that in the southern part of the continent, you have Mozambique, you have Zambia that I've just mentioned, there are some cases. It's important to push also the risk assessment in other countries, including Zimbabwe, to ensure that we can have a proper prevention. So far, we've recorded 11,294 total cases and 226 deaths, with a case fatality ratio of 1.9%. Remember that our target is really to go below the 1%. And so far, DSA is really the one reporting the highest number of cases, 69%, but also 80% of all the reported deaths. That's why there is a critical special attention to DSC, which will also organize this month the interaction review to see what should be changed, in which innovation should we address the issue of cholera. So cholera will also be part of the AU Summit side event with through the AU champion, the president of Zambia, His Excellency Ishilema, who will emphasize all the effort that has been put in cholera, including the continental plan, the task force that will be implemented, but more critically, emphasize the role that other sectors has to play on increasing the access to water, because when this access is there, then you have a better way of preventing and controlling cholera. Now, looking at the current country, so we mentioned that there will be some assessment in Zimbabwe because there are cases in Zambia, in Namibia, and other countries. So as I mentioned, DRC is still the country that that represent the majority, around 60% of 60% of the number of cases and 80% on the number of deaths. And this is happening on the side of Kinshasa, which you know very well is the capital city with over 20 million inhabitants. This is one of the most critical points, but also in other provinces, the South Kivu, the North Kivu, or Lomami. And the current conflict and displacement is still one of the key drivers of what we are seeing in DRC, but also affecting the neighboring country, which is Burundi, because the migration of the refugee also contribute to moving the cholera there. But as we are discussing today with the colleagues from Burundi, the multi-sectorial approach that they've been implementing, including specifically the private sector, is really pushing, moving the access to the quality water. So that is also one of the good examples that will be discussed. As you can see, even from the figure, the case fatality ratio is 0.4% with 14 deaths out of the 3,792 cases that has been reported in the 14 districts that out of the 46 that the country has. In Mozambique, we've seen that increase in the number of cases. This week, we reported 870 cases as compared to 296 last week. The number of deaths, as you can see, also has increased from 5 to 22. So we currently have 98 deaths with a case fatality ratio of 1 out of the almost 8,000 people that has been suspected. So 5 provinces have been currently affected. And one of the major drivers and challenges has been the recurrent flooding. I mentioned the cyclone that has been happening in those regions, Dikeledi, Ejud, and Nampula province. So the discussion that we've been having this week with all our partners, WHO, UNICEF, IFRC, is how to strengthen the regional response to that region, because we see countries like Mozambique currently affected. We know that Zambia has also been affected. We know that Zimbabwe is also exposed. How can we have a tailored support? In some of the country, it will be more on the side of preparedness. In other, it will be more on the side of the response. But all together, it's also come back to the cross-border collaboration, but more critically, the involvement of other sectors, especially the WASH, which has to be supported by the Minister of Finance. And once again, this will be part of the important discussion and side event that will happen this weekend in Addis Ababa in Ethiopia. Now, still in Mozambique, we observe a high number of community deaths across all reporting provinces. This might be linked to the gap in health-seeking behavior, low community awareness, or the challenge in accessing timely medical care. So on one side, we have the medical response, which need to be strengthened. And on the other side, we need the education, the empowerment of the community. And we go back to our survey on seeing if we can support the increase of community healthcare workers, then we have an impact on our primary healthcare, and therefore be able to control more early the disease in those communities. So there is an opportunity for outbreak control. The government has received 3.5 million of preventive OCV doses, which means that these doses will be used by 2 doses will be given in the population and 2.5 million reactive OCV. So the difference between the two, there is one mistake here. The difference between the two here is that the preventive with the 2 doses will provide a longer protection, and which is currently possible as it will also happen in DRC because the production have increased, but we need more. We need much more vaccine that we currently have, and therefore the local manufacturing is coming back as a critical point that will be discussed during the AU summit in the different side event. We know that I mentioned it will be discussing the health financing collaboration, the local manufacturing, the health workforce, the community health and immunization, and all that linking to the reform of global health architecture, where the continent has a voice and has a new willingness to lead what is happening in the continent. So as MPOS is concerned, we have seen the lift of the effects, but we see that some countries are still Madagascar, Mali, Comoros, which increased the number of countries affected. Vaccination remains a key tool to control, and we need to look beyond that, thinking about the herd immunity, linking once again to the local manufacturing. As cholera is concerned, DRC is now reporting the highest number of weekly cases and deaths, which require a particular attention. Climate change and humanitarian situation, the key driver that we are seeing, whether we are talking about the eastern part of DRC and Burundi in central part of the continent, or whether we are talking about climate issue on the southern part of the continent. So far, Mozambique and Burundi are major concerns which need the proper attention that they are receiving currently for the IMST. So with that, I will end the presentation. And once again, we have all our colleagues that are present to answer all the questions that you might have for us. Over to you, Director Margaret.
Thank you very much, Prof. Let's take the first two questions. We have one here from Sheriff Said, is a journalist in Gambia. The question is, as the Mpox cases still persist in Comoros and other countries, what is the paradigm shift contingency plan from Africa CDC for the countries currently hard hit with Mpox in order to contain the virus? That is the first question. The second question here is from Inez. Inez is a reporter with APM Market Access. The question is, does Africa CDC have continental regional visibility into medicines or therapeutic areas delayed due to missing local clinical trial data? If so, which face the greatest access barriers? I think that's a question for Professor Musoka. So I will hand over the floor back to you, Prof, for the first question.
Thank you. So Dr. Messi will be happy to handle the first question on the paradigm shift. And as you mentioned, Professor Musoka, on the issue of visibility due to lack of data from the clinical trial. Dr. Messi?
Thank you so much, Prof. Good afternoon, and thank you for that question. So yes, just like you mentioned, we still continue to see cases being reported in Comoros and other countries. But if you look at the curve and the numbers that we are seeing routinely, we really have observed a very, very steep decline compared to the peak period that was January last year. And in terms of what we are doing, definitely, as you know, we have different clades of Mpox being reported across the continent. We have countries that have been endemic for quite a while and have been reporting clade 1A. And we also have countries that, of course, springing up with clade 1B, who are kind of in the outbreak mode since 2023, when the clade 1B was detected. But in terms of what to strengthen their surveillance system, improve lab capacity, reduce turnaround time for detection, also improve on community healthcare workers' capacity to be able to detect at the communities, as well as improving on the case management bit, where we now understand how the virus, the pathogenicity of the virus, and we're able to target some risk groups. So case management is fairly doing quite well. We understand how better to contain or to treat the disease. But in terms of the bigger picture, looking at it from the public health space, what we are doing is we're transitioning countries to be able to integrate the response capacity systems for those countries that we use now and then. And so we can't continue to be in emergency mode. So what we're doing is we've developed an integration roadmap where we are supporting countries now to integrate the capacities that have been gained during the response into their routine healthcare systems. And that's what is currently being done. And then for countries that have not reported, we are also supporting them to be prepared, because initially Comoros was not reporting and had imported cases, and over 30% of cases that are reported in Comoros are still imported cases. So we need to ensure that other countries also have preparedness measures. They have the capacity to be able to detect and control at source when it's still being localized. So basically, that's then on the side of the vaccine. I think we are also still continuing to support countries in ensuring that they have their structures, their structures in countries to validate and approve. They have regulatory approval ahead of time, so that in case there's any eventuality of a spillover and maybe they plunge into an outbreak mode, they already have the right systems to receive the vaccines if they are available. Over to you, Prof.
Thank you. Mosoka?
Thank you, Prof. Yes, that's a very pertinent question. And we try to correct that, most especially during the mpox, where we had a single database to track all clinical trials from the clinical trial, epi trials. Now, the next stage we are trying to do to make this regular so that people can have access to a one-stop shop for all trials on the continent is we're trying to move a big platform from the group in South Africa to Africa CDC called cdc.africa. Yesterday, actually, we're discussing that. So everyone can have a one-stop shop to look exactly where different clinical trials are in stages. However, during the mpox, one of the things we've done, because we are conducting the only antiviral treatment for mpox, we've already used the media many times to publish exactly progress we are making. We want to take all of those experiences from mpox and create a one continental stop shop that anyone can access anytime. So, but we've done it already during the mpox, and we want to use those experiences to expand for other clinical trials. Thank you, and over to you, Prof.
Thank you. Papa.
Yeah. Yes, thank you very much. Let's cross over to the floor. We have Helen from START. Helen, you have the floor.
Hi, thank you very much for taking my question and for doing this very interesting briefing. I apologize for asking the same thing every week, but I am wondering if the Africa CDC has heard anything more about the status of the proposed hepatitis B birth dose clinical trial that the Bandem Health Project is proposing to do in Guinea-Bissau. Thank you very much.
Thank you, Helen. Let's take the next one before the response comes in. We have Kumba from Gambia Daily. Kumba, you have the floor. Kumba, if you can hear us.
Thank you for having me. Are you hearing me, please?
Yes, we can hear you. Go ahead.
Thank you once again for giving me the floor to ask my questions. I have 3 questions, but my first questions would be, what concrete step has Africa CDC taken in the past year to advance Africa health strategy targets? And how will this be accelerated following the discussion at the AU summit recently? And the other one would be, given the evolving nature of outbreaks, example, cholera, mpox, other emergencies, what new measures or innovations in disease surveillance and rapid response is Africa CDC championing to strengthening health security across member states? And the third one would be, how is, in terms of the health security, what accountability mechanism will Africa CDC advocate for to ensure that AU summit health commitments, especially in areas like maternal, child health, immunization, and disease elimination, are translated into measurable results at national and regional levels? Thank you.
Thank you very much, Kumba. Prof?
Thank you. Thank you so much. I think we have different questions. I will take the one of from Ellen on the hepatitis B, and then we have Mercy on the surveillance, and Dr. Landry, who will support on all what is related to primary healthcare. So, Ellen, as we will be hosting the side event, we'll have a ministerial meeting, and then part of the minister that will be present will have the minister of Guinea-Bissau, so that we also have those bilateral engagement to have that conversation and see, okay, since all those declarations, where do we stand? And then next week, definitely, we'll give you some updates. Dr. Mercy?
Thank you. Thank you so much, Prof. And thanks for that question. Thanks for that question. And I'm really happy that this is coming up. I also see the head of Division for Surveillance and Intelligence on the call. So maybe you might want to chip in once I make my submission. So regarding some of the innovative approaches or some of the initiatives that as surveillance within the Africa CDC we are doing, as you know, most of the emerging diseases are kind of being driven by climate change and other drivers, even security, movement, and all that. In the light of climate change, we just recently launched our climate change and health strategy. And this climate and health strategy looks at different components, supporting countries towards also identifying their vulnerabilities, as well as also helping countries to develop their health national adaptation plans, which definitely looks into the different areas that makes countries that increases the vulnerabilities of countries towards some of these hazards that we are seeing, or some of these diseases that are climate related. Secondly, around the difficulties that we also see in terms of detection during sociopolitical crisis. One of the things that we are doing, we are also trying to establish joint task force with our peace and security organ, whereby we are able to jointly monitor some of these events and also come up with protocols that can enable us harmonize our risk ranking and priorities. Thirdly, in terms of our workforce, if you realize, we had initially published the community health workers strategy, whereby we are really looking forward to building resilient community health workforce, looking at it from a polyvalent perspective. Initially, we know most of our community health workers were really focused on some of the vertical programs like polio, TB, HIV, but now we're trying to see that they are more or less being equipped to be able to detect across board. And this is also very cost effective as well as sustainable in nature. So those are some of the things that we are beginning to do to adapt to the current surge in the diseases that we are seeing.
Thank you, Mercy. Dr. Landry?
Yeah, hello. Dr. Landry is not there.
Oh,
Dr. Landry is there?
yes, he had.
I seem connected from 2.
Perhaps we can take the next question then, and then he can answer the
Yes,
next
but
round.
I can answer there was one question on the health target, and that will be presented. What I've presented to you, the few slides on the survey, it's one of those tools that we'll bring tomorrow to the head of state so that they can appreciate the very clear indicator of all the work that they've been doing in the different countries, but also to see what is needed to move forward. You remember, taking the simple example of the community health worker, we have a target of 25 community health workers for 10,000. And this one, we have only 6 countries that have managed so far. So that will also make the connection with the domestic financing that we are pushing. So that on one hand, we are supporting countries, giving them the targets, showing some good example, but also, in the other hand, we support through the Accra Reset and so on to see how we can also support them in more efficiency. If you recall, we'll be sending 20 finance officers in some of those countries to ensure that they have those improved in efficiency on managing their fund. Over to you, Director Margaret.
Thank you, Prof. I've been informed that Barnabas will stand in for Dr. Landry in case there are any questions. So let's get the next question here. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. Good afternoon.
Good afternoon. Welcome.
Thank you. I want to, given the improvement we had about genome sequencing at the height of the response, the mpox response last year. I want to know how much we know now about two things. Firstly, at the start of it, at least from my own knowledge, we know that certain clades were endemic to certain regions of the continent, west and the southeastern regions. I want to know how that has changed, if it has. If we now have all these clades in all these regions, or if we are still stick to what we knew before now. And also, not much, even though we heard about sexual transmitted, mpox that were sexually transmitted. At least we heard a lot about this, but it wasn't clear. And at some point, experts were avoiding speaking about it. Has there been any change in it? How much do we know now in terms of sexual transmission of mpox? Thank you.
Thank you. Back to you, Prof.
Yes, so I will answer the first one on genomic sequencing, and let Dr. Mercy answering on the sexual transmission and where we are now in terms of those data. So for the genomic sequencing, yes, you are right. We've managed to move to 46 member states currently having the capacity to do the genome sequencing. And what has been the result of all that, starting from DRC? You mentioned that initially we were dealing with our mpox, the clade 1A on the one side of the continent, the clade 2A on the other side. And the mutation through genomic, we've managed very quickly to identify what was happening and the transition. So now, as we do speak now, the first thing that we look in a country where we have some case is to find out the clade, because the clade will define the way we are going to respond. And that is happening in all the countries that have been currently affected. And that is an important legacy from these outbreaks. Now, we have countries like Cameroon. They did the sequencing, and they realized that they were actually having the clade 1B and the clade 2B. Those are two sexual transmissible clade. And the central position of the country mean that you have the clade 1B coming from the eastern part of the continent and the clade 2B from the western part. And those information are critical. And I will let Dr. Mercy complement on the issue of the sexual transmission from the data that we have managed to gather so far. Over to you, Dr. Mercy.
Thank you so much, Prof, and thanks so much, Kim, for that very interesting question. Just like Prof mentioned, we still are seeing a cocktail of clades on the continent affecting different countries, and the distribution, why some countries might be reporting several clades, there are 6 other countries that are reporting just single clades. For instance, you have countries like Cameroon that are reporting clade 1A, B, clade 2, and all that. So that's the situation, and that's how we still see it. However, in terms of sexual transmission is just a type of contact, it's type of intimate contact. And we want to keep it that way because when we emphasize a lot and say it's strictly sexual contact, sexual transmission, we now, are also kind of removing the other type of contacts that could be looked into during some of our contact listing and all that. So basically, sexual contact is part of intimate contact, so it's just a part of contact. And clade 2B, clade 1B, that of course we know that we've seen more or less human-to-human transmission. Also are transmitted through close contact. We've seen household, mother-child, close contact, and sexual contact is just so one of them. In other countries like Sierra Leone, we were seeing that in sexual networks. In Madagascar, we also saw that in sexual networks, and that is why it's one of the approach that is being used is engaging with some of those communities and NGOs that are really supporting that area to be able to advance risk communication, community engagement, and also support with awareness around the areas, just so that we also minimize on the the stigma around putting such a nomenclature out there. Over.
Thank you, Mercy.
Great. Let's take the next question. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much for this opportunity. My question is almost similar to the last one, and which has to do with prioritization of control measures. I know you mentioned risk communication, but we've always been talking about vaccines a lot, which makes it concerning that we seem to be a lot of communication and reporting on our response to Mpox has been how many countries have gotten vaccine and risk communication. So can we have insight into what has actually been done regarding other means of controlling it? Because even when we talk about cholera, we still talk about how many countries are able to access vaccines. Meanwhile, we have other public health measures. So if there is anybody that can provide a robust response regarding specifics on what has been done beyond just vaccine access, I will appreciate that. Thank you very much.
Thank you, Paul. Prof, back to you.
Yes, thank you. Thank you so much, Paul. You are right. I think maybe when we mention vaccine, it's sending the message that it's only through vaccine that we can solve Mpox, which is not true. We agree with that. We still have the example of country like Burundi, like Namibia. Burundi has an important peak at some point, and then they use the early detection. Let me start with the first one, actually. You remember we published an article on the key driver for the successful response to Mpox. And in those key drivers, actually, vaccine were not part of it. The first one was the leadership of the Minister of Health to be involved. And if you recall, at some point, we were highlighting that in Burundi, for example, the Minister of Health was present during the interaction review, during the entire process to ensure that all the recommendation will be implemented. You also recall what has happened in Sierra Leone, where the community-based surveillance, the integration, where we have the surveillance, we have the RCC, we also have the vaccine, yes, but those measure was quite critical. We have the detection, the decentralization of the laboratory. I mentioned that is one of the challenges that Madagascar is currently facing. And the effort that has been implemented in Burundi, in Malawi, in DRC, moving in some of those countries from one laboratory to 56 in Burundi, for example, that reduced significantly the time between we have a suspect, between the time the suspect is detected, and the other key driver that we are always highlighting is the isolation of the positive case in health facility. One, to provide the most adequate and efficient care, but two, also to stop the transmission. Because when you have them at home, you cannot ensure 100% that they won't continue to have some extra relation, extra contact, especially when they have those mild cases. And the last one that we highlight as one of the key drivers is the data, the unified database. The ability for a country to know exactly the number of suspected cases, the number of positive cases, where those people are at some point, that is what will support them on having a targeted approach for the vaccine that come now on top of all the other measures. So thank you so much for that question to reemphasize that the vaccine is not a silver bullet, but it's an important component that come on top of all the other measures that are implemented. I hope this is answering your question.
Thank you, Prof. Let's take the last question here. We have Rachel Abuja from Nigeria News Agency. Rachel, you have the floor.
Thank you for this opportunity, Millicent, and good afternoon, Prof, and everyone there. Now, I have a serious problem. I'm somewhere in Cross River where I came to monitor the vaccination process, the campaign that Nigerians are having. I don't know if we're aware of it. And I found out that we have immune-compromised children that are not able to get this vaccine. And going through some researches and some other thing around from 2 days ago till now, I found out that these children are left behind. And if we say we have to checkmate with their caregivers and clinicians, do we have other options that these children can be with, that what will make these children to be saved instead of going not being vaccinated, instead of us having them mixed? What plans do we have for them? Because from the look of things, when we send these vaccines across the continent, we don't consider this group of people, or do we? I would like to hear from you, Prof, so that we can start raising awareness on this and also advocacy, because people, caregivers, they tend not to understand all of this. And I think it's high time for us to expose what is happening so that they can be well informed and know when their words can be vaccinated or not to be. Thank you, and over.
Yes. Okay. Thank you so much, Rachel. I think this is a great question and an opportunity to reemphasize the advocacy. And I will let Dr. Charles Ebeneme to answer that question on what is the current situation of the vaccination for children, why in some countries children are not vaccinated while the vaccine are available on one side, but also while they are actually vulnerable. Over to you, Dr. Charles.
Yeah, thank you so much. Thank you so much, Prof. Yap, and thank you for that wonderful question that was asked. So what we have seen over time is while in some countries, for example, like DRC, children have been vaccinated, but in some other contexts, children are not being prioritized for vaccination. This actually boils down to issues of regulatory clearances based on different countries and different contexts. So because the MVABN that is currently being approved for use has been approved off-label use for children from 1 year and above, based on SAGE recommendation, actually. But then we've seen some country regulatory authorities not yet been approving these vaccines for use, probably because of the liability issues that are, that follow some of these discussions. However, from data availed from countries like DRC, from countries like Malawi, that have actually vaccinated children below that threshold from 1 year and above, we've actually not recorded any form of adverse events, serious adverse events from the use of these vaccines. And as such, we on our part, in the vaccine pillar, have actually advocated for countries to consider this particular age groups of persons during vaccination. However, what we also do recommend is also using other non-therapeutic measures especially for countries that have not been able to approve the use of the vaccines, possibly due to probably death in data and the likes, pending when they did get these recommendations from the countries, to also employ some non-therapeutic measures like IPC, like RCCE, for the children. But basically straightforward is the vaccine have been found potent for use, off-label, of course, for these particular age groups, and we've been encouraging countries to do the same. So maybe what we can do is to increase the advocacy, and good thing you mentioned Nigeria. We would also try to, engage our colleagues in country to see how to expand these advocacy discussions, to expand the cycle nets to cover for this age group of persons. Thank you, and back to you, Prof.
Margaret?
Yes, thank you, Charles. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you, Prof, for your closing remarks.
Thank you, Margaret. Thank you so much to all of you, all the journalists, and all the colleagues who are joining for the press briefing. And thank you for those questions, because the answer to those questions serve many purposes. One, you have the right information. Two, you become our advocate, because when Rachel will write now an article on the possibility to avail vaccine for children, then at some point it will make its way to ensure that now Nigeria will revise the availability and actually the approval for the vaccination for this specific population. So all that is, all the discussion and what is happening this weekend, it's about how the continent, with the support of Africa CDC, is contributing to the reform of the global health architecture. And then we'll have those conversations which will happen with our aid champion. This will happen around the health financing, the local manufacturing, the community healthcare workers, the immunization, and of course the health financing. We know that money is so critical. And if you recall, the Accra Reset and the Africa Health Security and Sovereignty will move together so that we can invest on the more efficiency so that we stop the old narrative of the head, but rather emphasizing on getting the best of what we already have to cover and protect our community. So thank you so much, and then we'll be happy to be with you next week at the same time. Thank you.
Recording stopped.